right, good morning, everyone. Thank you. I'm thrilled to be back. Today I'm going to be presenting on the impact of plans of safe care on prenatally substance-exposed infants. And hopefully you can see my next slide here. We have no conflicts of interest to disclose. Of note, an interagency memorandum of understanding established to support data sharing for this project. And in part, funding source is NIH. So approximately 1 in 8 children ages 17 or younger nationally live in households where a caregiver struggles with substance use. Substance use disproportionately affects young women of childbearing age, resulting in increasing proportions of infants born prenatally substance exposed, or IPSE, and we'll use this commonly accepted acronym for the remainder of the talk. Caregiver substance use negatively impacts parenting and placement stability and represents a leading risk factor for foster care entry nationally. Been associated with increased risk of child abuse or neglect, and federal fiscal year 2019 data suggests specifically that across 29 U.S. states, nearly 20% of child fatalities involved a caregiver drug abuse risk factor. How best then to support IPSE merits really urgent attention, but has proven challenging for public health and child welfare. That's primarily due to population heterogeneity. So, for example, parenting mothers may struggle with active addiction, or in contrast, they may birth an infant who exhibits withdrawal symptoms related to appropriate maternal pharmaceutical use for a medical condition or underlying mental. Recent federal statute changes now specify that child welfare agencies must be notified after IPSE birth in order to comprehensively address mother IPSE needs through what's called development of a plan of safe care. Plans of safe care are theoretically non-punitive, family-centered, child welfare-based programming efforts, inclusive of community-based referrals to local resources like parenting classes. Yep.
I hate to interrupt, but for some reason we are only seeing the first slide.
Oh.
It's not advancing.
Hold on. What do you see now?
Still the first slide. Oh,
Right.
now we see your disclosure slide.
Okay. Right. I was here.
Okay, sorry about that.
I'm having some technical issues for some reason with movies this morning, but anyway, so plans of safe care are theoretically non-punitive and family-centered child welfare-based programming, inclusive of community-based referrals to mental health, substance use disorder treatment, parenting classes, and home visiting nursing. And so while federally mandated by statute, many states across the nation are really in varied stages of plan of safe care program development and implementation, with little outcome or efficacy data available to inform best practices. So while federal data indicates that in fiscal year 2019, over 38,000 IPSE were reported to child welfare nationally, 75% of whom were provided plan of safe care support, little is actually known regarding the impact on IPSE outcomes of this plan of safe care programming. We were interested in understanding how plans of safe care affected IPSE across the state of Delaware, where plans of safe care were uniformly implemented statewide in 2018. So we aim to assess IPSE and family population characteristics reported to our statewide child welfare agency, assess the distribution and type of plan of safe care referrals to community-based programming, and examine associations between IPSE, family, and plan of safe care characteristics and child abuse or neglect outcomes. So our outcome of interest was child abuse or neglect defined as the IPSE sustaining a physical injury or an abuse-related fatality after birth. So a previously established memorandum of understanding had permitted data sharing between our institution and Delaware Division of Family Services, our statewide child protective services agency. And that enabled us to retrospectively review Delaware's statewide CPS case registry data, specifically regarding IPSE birth notifications and any subsequent hotline reports for abuse or neglect received November 1st, 2018 and October 31st, 2020. And the abstracted variables from this case registry included IPSE level characteristics like gender and substance exposure type, family level characteristics such as maternal personal child welfare history, maternal mental health diagnosis, and then plan of safe care level specific metrics, including programmatic components like referrals for mothers, fathers, and IPSE, whether a safety plan had been instituted by Child Protective Services, or whether out-of-home placement was necessary. The descriptive statistics for IPSE family and plans of safe care characteristics are reported in the following slides, and then cases involving child abuse and neglect were analyzed qualitatively for trends, which I'll go into. A total of 1,436 IPSE were included for analysis. And calling your attention to the red arrows, 54% of IPSE were female, with over half of mothers identifying as white. Most mothers did not have a valid prescription to account for the identified substances of prenatal exposure on toxicology testing. Nearly 90% of IPSE avoided out-of-home placement. Nearly 1/4 of mothers had delivered a prior infant that was prenatally substance exposed. Most mothers had comorbid mental health diagnoses. 30% of mothers had personal histories of childhood involvement themselves with Child Protective Services in the state. Looking more in depth at substance exposures and calling your attention to the text box, the majority of IPSEs, 66.8%, had single substance exposures versus those that had polysubstance exposures. And highlighted by those adjacent red arrows, marijuana-only exposures represented the majority of single substance exposure types. Medication-assisted treatment or opiate MAT, including Subutex, Suboxone, and methadone exposures, accounted for the second most common exposure type, followed by opiate non-MAT exposures, and then finally cocaine. So here's our substance exposure data presented in an alternative format, which I think more clearly details some of these important trends. So calling your attention to the bolded substances demarcated with the red arrows, first in column A, you can see that nearly 75% of all marijuana exposures were to marijuana alone, or as a single substance. So in other words, only marijuana was detected on the toxicology testing. And in contrast, in column B, you can see that for alcohol, amphetamines, barbiturates, benzodiazepines, cocaine, non-MAT opiates, and synthetic opioids, like heroin, fentanyl, and codeine, those substances were used in combination with other substances most of the time, occurring as polysubstance exposures anywhere from 81 to nearly 90% of the time. So regarding plans of safe care, a total of 1,347 plans of safe care were developed for nearly 94% of our total study sample. 89 IPSE had no plans of safe care, and that was due to the following reasons: either being placed out of home at birth hospital discharge, or due to being screened in by Child Protective Services under circumstances in which the family was already open with Child Protective Services at the time of infant birth due to safety issues that were involving another child in the household, resulting in either implementation of a safety plan, treatment service provision in lieu of that plan of safe care. And now looking more specifically at plan of safe care referrals for mothers and fathers, 43.5% of IPSE mothers and 9.1% of fathers were referred to community-based service providers. And this included substance use disorder treatment, mental health treatment, parenting classes, home visiting nursing, among others that are listed in that first column. 27% of mothers were referred for substance use disorder treatment, whereas 13% were referred for mental health treatment. Other percentages were referred for parenting. For fathers, you can see most referrals were to substance use disorder, 1% to mental health, 3.2% for parenting. Nearly 58% of all the IPSEs themselves were referred for plan of safe care services, with nearly half being referred directly to a pediatric medical home to facilitate longitudinal follow-up. Notably, nearly 1/5 were referred to developmental pediatrics or early intervention services here in our state for a neurodevelopmental evaluation specific to the in utero substance exposure concern. 16.3% were referred to home visiting nursing. And next, we qualitatively reviewed 11 cases of child abuse or neglect in our cohort for whom plans of safe care were developed. So briefly, the variables that we assessed were substance exposure type, whether a safety plan had been instituted, where plan of safe care referrals were made, maternal treatment engagement prior to the delivery, and then maternal factors like childhood involvement with Child Protective Services and maternal mental health history. We have a further description of that serious physical or fatal injury. So notably, 0.82% of IPSE with plans of safe care were seriously physically or fatally injured. So only 11 out of that 1347. 5 of 11 cases involved single substance exposures. 5 of 11 cases involved marijuana exposures, with 3 of those 5 involving marijuana only as the single substance. 6 of 11 cases involved a concurrent safety plan that had been established prior to birth hospital discharge. And then looking more specifically at the injury types, 5 of 11 involved fractures, while 3 of 11 cases involved infants that were asphyxiated during bed sharing events. Looking more specifically at moms, 7 of 11 mothers were prior to the plan of safe care implementation. 6 of 11 had personal protective services involved here in the state. So comparing the overall proportion of substance exposure types in our population to those that are represented specifically in the PACT cohort, we see that polysubstance exposures account for around 1/3 of all exposures in the overall IPSE population. They're overrepresented in the abused and neglected group, whereas the opposite is true for marijuana. So this study clearly has some limitations. It's a retrospective review subject to errors in data abstraction. Notably, confounders may have impacted our reported abuse and neglect rate, not specifically assessed for in our analysis. Our study lacked any kind of specific input from either family members, service providers, or child welfare professionals regarding the actual referral utility or the efficacy of interventions. We had a small sample of abused and neglected IPSE, so clearly that limited a more robust statistical analysis. Yet, despite this, our study is pretty novel in that it represents one of the earliest analyses across the country on a broad statewide level of components of plans of safety and then the impact on rates of abuse. So our results really suggest that families have diverse needs, but most do require linkage with some community-based resources. Which specific referrals actually best support families affected by substance use though requires further in-depth study and really should be informed by qualitative analysis or some direct family and service provider input. Our research team had previously analyzed factors associated with child welfare involvement among 1,222 IPSE pre-plan of safe care implementation in the state. And in that study, an abuse and neglect rate of 2.3% was identified among IPSE. Notably, in our present analysis, as I mentioned, after plan of safe care programmatic implementation, our abuse or neglect rate is down to 0.82%. So clearly, we can't establish any kind of causal relationship, but this does suggest that plans of safe care do in some way impact abuse or neglect outcomes for this population. So in conclusion, while further study is needed, the initial results suggest that plans of safe care do promote linkages to community-based programming and may impact abuse and neglect rates among vulnerable IPSE. So thank you. If you have any other questions, I'd be happy to answer them now. And thank you to my collaborators, Dr. Jiyoung, Jubair Hussein from the Excel program, Jenny Parker, who is the Director of Delaware Division of Family Services, and Jen Donahue, who is the investigation coordinator for the state. And importantly, Clara Loisel, my research assistant.